Welcome back to the deep dive. Today, we're tackling a field that's as critical as any science, but it's
Yeah.
something we talk about far less in the lab. We're looking at the really challenging ethical landscape of modern medicine.
hmm
Because when a physician opens a foundational text like Harrison's Principles of Internal Medicine, they're looking for more than just, diagnostic criteria.
That's exactly right. They're looking for guidance on how to navigate this
Mhm.
this daily moral wilderness of human choices.
Right.
Clinical medicine is, I think, often wrongly simplified. You see it as this clean process of diagnosis, then treatments.
Yeah, A then B.
Exactly.
Yeah.
But for physicians on the ground, the reality is a continuous stream of really difficult moral choices.
And these aren't just theoretical classroom questions.
No, not at all. These situations cause deep perplexity. They lead to what we call moral distress, and they fundamentally test the integrity of the whole doctor-patient relationship.
So our mission today is to distill that core ethical guidance that physicians rely on, and we're taking it straight from Harrison's text. We're going to explore how the profession deals with both those age-old dilemmas and the brand new ethical pressures that are coming from technology and big systemic changes.
Yeah, and the text sets this up beautifully, I think. It divides this ethical world into two categories. You have the enduring and then the novel.
Okay, so let's start with the enduring. What are those constants that have always been part of medicine?
The enduring dilemmas are those things that have, well, always plagued care, like deciding the appropriate intensity of care for a patient who is nearing the end of life. That's a classic.
That's never going away.
Never. Or the challenge of justly distributing a doctor's limited time and energy among multiple critically ill patients.
How do you choose?
How do you choose? Or even just ensuring a patient can actually access the care they desperately need. That's a huge, enduring problem.
Tragically timeless problems. So what about the novel dilemmas? What are the new forces that are, opening up these fissures in medical ethics today?
We're seeing three main drivers, really. First is the rapid adoption of artificial intelligence, AI, and machine learning.
Okay, the tech side.
Right. And while it promises all this efficiency, these technologies raise some serious ethical questions about confidentiality,
Yeah.
about where accountability lies when an algorithm fails.
Who's responsible? The doctor, the programmer.
Exactly. And how does this data-driven approach fundamentally reshape that classic personal doctor-patient relationship?
That's a huge question. So that's technology. What about the structure of care itself?
Well, second, you have the increasing dominance and just complexity of for-profit healthcare enterprises.
Hmm.
And these introduce new financial conflicts of interest that often pit the corporate bottom line against the patient's actual best interest.
And the third driver.
The third is a necessary and frankly heightened focus on health disparities. The ethical imperative to address variations in care quality based on non-medical factors like race or socioeconomic status is forcing a huge systemic reckoning.
This sounds much more like a skill set than just a rule book you memorize.
Well, absolutely.
Harrison's seems to suggest that ethical judgment isn't something you learn once in medical school and then you're done.
It's lifelong learning, completely. Ethical practice is not about memorizing a checklist. It requires physicians to continuously reevaluate their own deeply held convictions.
Right.
Cultivate a high tolerance for uncertainty, commit to seeking out the views of everyone involved in the patient's care, and really know how and when to use institutional resources.
So what does that look like in practice? If a physician hits a truly complex ethical wall, what's their lifeline?
The primary resource is the interdisciplinary healthcare team. You're talking about nurses, social workers, spiritual care professionals. They all offer these unique, essential perspectives.
Well, it's a team sport.
It has to be. But if the moral perplexity persists, physicians are encouraged, I'd say even obligated, to use formal mechanisms like ethics consultation services or dedicated hospital ethics committees.
And what is the committee's job? Are they there to just tell the doctor what to do?
No, their job is far more nuanced than that. They're there to clarify the issues, to identify various morally defensible options.
Okay, so options, not orders.
Exactly. And to improve communication, especially when emotions are running high. And ultimately, to help the team arrive at a strategy or resolution that is mutually acceptable and, ethically sound. The text really emphasizes that using these resources is crucial for gaining deeper insight and moving past complexity toward a decisive, defensible action.
Okay, that sets the stage for the complexity. So now let's talk framework. Before a physician can navigate these complex cases, they have to rely on a set of guiding principles. where does this ethical guidance actually come from?
It's really synthesized from four main sources. First, you have the widely accepted core ethical principles, which are the structure we're about to discuss.
Right.
Then you have virtue ethics, which focuses more on the character of the physician.
Okay.
And then there are professional oaths, like the Hippocratic Oath, which provide these ideals. And finally, you have the physician's own personal values.
And the challenge, I imagine, especially in a modern, diverse society, must be that these sources often conflict with each other.
They do, all the time. General moral precepts are rarely a perfect fit for a unique clinical situation. The real skill is in interpreting those general rules and applying them carefully to the specific circumstances of the patient right in front of you.
And that's why we have this framework.
That's why we rely on the four main principles, which serve as these robust shared guidelines for determining the right thing to do.
Yeah.
Okay, let's start with the first one, which feels like maybe the most revolutionary concept in modern medicine: respecting patients, or autonomy. What does that require a physician to actively do? It means treating the patient with dignity and recognizing that their goals, their interpretation of their own illness, and their life context are completely unique to them.
Clinically, this translates to several key actions. Understanding the patient's goals for their care, providing full and relevant information without holding anything back, ensuring effective communication, and consent.
Right. Obtaining informed and voluntary consent, respecting informed refusals, and fiercely protecting their confidentiality.
So autonomy is really about ownership over one's own body and fate. It's a recognition that health is valued differently by every single person.
Exactly. The source highlights that clinical goals are rarely monolithic. I mean, there are often multiple medically feasible pathways, and every single intervention comes with its own unique balance of benefit and harm.
Right.
Individuals differ profoundly in how they value health, how much they fear specific risks, and how they weigh quality of life versus quantity of life. The ethical obligation is to respect the patient's personal, informed values and their choices, even if the physician would choose a different path for themselves.
And you mentioned that respect takes on a really critical weight in certain patient populations.
Yes. The text is very clear that respect is paramount when patients have experienced or even just harbor concerns about historical or systemic disrespect and discrimination.
So this is directly addressing things like racial bias in medicine.
It's directly addressing the need to rebuild trust, and it acknowledges the systemic barriers that affect patient populations based on race, ethnicity, or other non-medical characteristics. This requires the physician to be acutely sensitive to the patient's experience in the healthcare system.
Okay, so the second pillar is beneficence. This is the core duty to act for the patient's best interests. This is the cornerstone of trust, right?
It is. It's the requirement that the physician must actively strive for the patient's benefit, rely on compassion and their expertise. When people are ill and vulnerable, they often lack the expertise to guide their own care, so they place this immense trust in the physician's sound recommendations.
And this is tied to the concept of fiduciary duty, isn't it?
It is. The physician holds a fiduciary duty, which means they have a professional obligation to prioritize the patient's best interests above all other conflicting interests, including their own financial or professional gain.
Now, beneficence is almost always paired with its counterpart, non-maleficence, or primum non nocere. First, do no harm.
Right. Non-maleficence obligates physicians to prevent unnecessary harm, so you're maximizing the benefit of interventions while minimizing the harm. It forbids providing ineffective or unproven interventions or, acting without due diligence or care.
But Harrison's points out a nuance here, that this precept alone is limited.
It's very limited.
Why? I mean, if I'm a surgeon, I'm clearly causing some harm by cutting someone open.
Precisely. Almost all beneficial interventions, we're talking chemotherapy, surgery, potent drugs, they all carry serious risks and potential harm.
So it's not a zero harm game. Not at all. The ethical goal isn't to eliminate all risk, but to engage in a really careful risk-benefit analysis that's aimed at maximizing the patient's overall good. The two principles work together. We do good, which is beneficence, by ensuring the good outweighs the harm, which is non-maleficence. That makes a lot of sense.
So moving to the third pillar, justice. We often use this word in a legal context, but what does it mean in a clinical setting? Justice means fairness, that people should receive what they deserve or what they are owed. In healthcare, it demands similar treatment for similar people in ethically relevant ways. The core purpose of the principle is to eliminate arbitrary, biased, and unfair decisions from care delivery.
So justice is the principle that directly forbids discrimination.
Absolutely. Justice forbids discrimination based on characteristics that are not ethically relevant to medical care. Things like race, religion, gender, sexual orientation, disability, age, or socioeconomic status. A treatment plan should be driven by medical need and potential for benefit, not by who the patient is outside of that medical context.
And the scope of justice extends beyond just the individual interaction to the collective distribution of scarce resources.
Right, it governs resource distribution. Justice states that important resources, whether it's the physician's own time or a critically needed drug, should be distributed equally or according to morally relevant factors.
Can you give us an example of a morally relevant factor?
Sure. Need and probability of benefit are the big ones. So if we have two patients who both need a certain intervention, but patient A has a far greater need or a far greater probability of survival if they're treated, those factors become morally relevant for prioritization. Justice ensures that when difficult allocation decisions have to be made, they're based on these relevant clinical criteria, not on bias.
Okay, so that framework autonomy, beneficence, and justice is the ethical spine. Let's dive into how that first principle, respect, is actually applied, because this is where principles become protocols for things like informed consent, capacity assessment, and confidentiality.
This is the operational side of ethics, yes. Yeah. This is where we ensure the principles are met in the daily chaos of the clinic or the hospital floor.
So shared decision-making requires the patient to be a true partner, which relies entirely on transparency. What's the scope of what Harrison's calls the information imperative?
The physician must provide accurate, relevant, and comprehensive information. This includes the current diagnosis, the expected course of the illness, the prognosis, all available treatment options.
Including doing nothing.
Including observation or no treatment at all. And crucially, the inherent uncertainties and risks that are associated with each of those options. This is all essential for aligning the treatment with the patient's overall goals. Harrison's also addresses that powerful psychological temptation that many doctors face, withholding bad news to spare the patient anxiety. Why is the text so insistent that honesty has to prevail? The fear is real that disclosing a serious prognosis will cause anxiety or depression or hopelessness. But the text stresses that honesty is paramount because it promotes two absolute necessities: patient autonomy and trust in the physician.
Right. Without the information, you can't have autonomy.
You can't. Without accurate information, the patient cannot make an informed choice, and the relationship is ultimately built on a falsehood.
So what are the recommended strategies for delivering bad news while still maintaining support and empathy? It's not just about blurting out the facts.
No, it requires immense skill. Physicians have to adjust the pace of the disclosure to match what the patient can actually absorb. They need to use clear, understandable language, offer empathy, provide immediate emotional support,
And bring in the team.
and utilize resources like spiritual care or social workers. It is an active care, not just a fact delivery. The text also acknowledges, importantly, that in some cultures, patients may delegate the right to receive bad news to a family member, and that preference also has to be respected.
Let's clarify the definition of informed consent. I think in the public eye, it's often just reduced to signing a document.
That is a critical misconception. Informed consent is so much more than just obtaining a signature on a form. It's an interactive, continuous process.
A conversation.
It's a conversation that requires the disclosure of honest, understandable information to promote genuine comprehension and choice by the patient. The physician's job is to confirm that the patient has grasped the key diagnoses, the potential risks, and the benefits.
And we're hearing more about decision aids in this process. What role do they play?
Decision aids are structured tools that are becoming increasingly important because they help patients actively participate in the decision-making. They actually improve the accuracy of the patient's perception of risk and benefit, and they help them clarify their own values before making a choice.
So it ensures the decision is truly aligned with what they want.
Exactly, with their personal goals.
We've established that autonomy gives the patient the right to choose among reasonable alternatives or to refuse recommended treatment. Are there limits to what a patient can demand?
Yes, absolutely. Autonomy is not a blank check. Physicians are not obligated to provide care that is medically inappropriate.
What does that include?
This includes interventions that have absolutely no physiological rationale, treatments that have already been proven to fail, or options that are contrary to established evidence-based practice and sound clinical judgment. For example, a patient cannot demand antibiotics for a viral infection if the physician believes that violates good clinical practice.
And societal policies also set limits, correct?
That's right. Laws and public policies govern certain areas, like the allocation of scarce medical resources during a crisis, or state laws regulating access to sensitive procedures like physician aid in dying. The physician operates within these external legal constraints.
Okay, so the right to informed consent relies entirely on the patient having decision-making capacity. This seems like one of the most difficult and high-stakes assessments a physician has to make.
It really is.
How do we clinically define capacity? What are the core abilities a patient must demonstrate?
A patient is considered to have capacity if they can reliably do four things. 1, express a choice. 2, appreciate their medical situation and the potential consequences. 3, understand the nature, risks, and benefits of the proposed care and the alternatives.
And the fourth.
And 4, grasp these consequences in a manner that is consistent with their underlying values. This ensures the choice isn't the result of some temporary impairment like delirium or a delusion.
So capacity is generally determined by the physician, not necessarily a court. How is this complex assessment managed?
Physicians use a combination of resources. There are validated assessment tools, their own clinical judgment, and consultations, often involving psychiatry or ethics teams. It's a decision made specifically about the patient's ability to make particular healthcare decisions at a specific time. And the text makes a crucial distinction here. Simply refusing treatment doesn't automatically mean a patient lacks capacity. That is a critical ethical guardrail. Disagreement with a physician's recommendation does not equate to incapacity. If a patient refuses treatment, the physician's job is to carefully probe that decision, to make sure it's not based on a misunderstanding or misinterpretation of the facts.
But if they are informed,
But if the patient is fully informed and capable, their refusal must be respected.
what happens when capacity is lacking, say, due to advanced dementia, or a patient is unconscious?
If the impairment is temporary, decisions should ideally be postponed until capacity recovers. If the incapacity is long-term, then the physician must seek an authorized surrogate decision-maker.
How is that surrogate legally and ethically authorized?
Well, the patient's preferences are prioritized first. They may have designated a healthcare proxy through an advance directive, or a PLEST, which is a portable order for life-sustaining treatment, and these must be respected.
And if there's no document?
If no formal document exists, most U.S. statutes provide a hierarchy, which typically prioritizes close relatives.
When a surrogate is making these huge, life-altering decisions, what is their primary ethical guiding principle? Is it always to just choose what they think the patient would have wanted?
The primary guiding principle is what's called the substituted judgment standard. So yes, decisions should be based on the patient's known values, goals, and previously expressed preferences.
But there's nuance.
There's nuance. The patient's current best interests may occasionally justify overriding earlier, less specific preferences, especially if the current intervention promises a significant and unforeseen benefit, or if the earlier preference doesn't really apply to the specific medical situation they are currently facing. The surrogate acts as the patient's voice, guided by the patient's life story and values.
And what about the highly complex and just sad situation of the unrepresented patient, someone who has no family or appointed proxy?
This presents a very difficult ethical and legal dilemma. The text requires that these situations must proceed through a fair and careful institutional or legal process. So you might involve public guardians or court systems to ensure the patient's rights and interests are protected, even when they lack a clear representative.
Okay, so the final element of respect is maintaining confidentiality. This seems integral to the entire enterprise of medicine.
It is.
It sounds obvious, but why is confidentiality ethically foundational beyond just, respecting privacy?
It's foundational to patient autonomy and privacy, yes.
Yeah.
But critically, it encourages patients to seek necessary treatment and to discuss sensitive problems candidly with their physician. If a patient fears disclosure, they'll withhold vital information necessary for an accurate diagnosis and effective care.
But we know confidentiality is not an absolute right. There are situations where a physician must, or is permitted to, breach it. When does that duty shift?
The duty shifts when there is a risk of serious and probable harm to third parties or occasionally to the patient themselves. But breaching confidentiality requires meeting 3 very strict criteria to be ethically justified.
Let's unpack those 3 criteria conversationally, because this is where the law and ethics really meet.
Okay, so first, to override confidentiality, the risk must be deemed serious and probable. It can't be some vague or distant possibility. It has to be imminent and highly likely.
Okay, high bar. What's second?
Second, no less restrictive measures can effectively avert the risk. Have you tried talking to the patient? Have you tried mediation? Only if those fail can you consider disclosure.
And third?
And third, the adverse effects of overriding confidentiality, so the negative impact on the patient and on public trust must be minimized and socially acceptable.
Can you give us some common real-world examples of when a physician is required to breach confidentiality?
The most common triggers are mandatory public health reporting laws. This includes reporting infectious communicable diseases like tuberculosis, certain sexually transmitted infections, and, critically, mandatory reporting of elder abuse, child abuse, and domestic violence. In these cases, the disclosure is necessary to protect vulnerable individuals or the community. The duty to the public outweighs the duty to the individual patient's privacy.
That comprehensive look at respect really moves us into the systemic and structural conflicts that affect beneficence and justice. I mean, how difficult external factors make it to fulfill that duty to act in the patient's best interest.
Right. This section really highlights the tension between the individual ethical act and the, frankly, flawed system in which that act has to occur. So let's start with a classic moral challenge. Patient refusal. We respect informed choice. But what if a patient's refusal is clearly irrational or is thwarting their own health goals? Harrison's uses the classic example of a young asthmatic adult who's refusing mechanical ventilation for a readily reversible respiratory failure. To simply accept that refusal immediately is considered morally insufficient.
You can't just walk away.
You can't. The physician's primary duty is to engage in robust persuasion. They have to elicit the patient's concerns, correct any misunderstandings, and really try every avenue to convince them to accept this highly beneficial, life-saving therapy.
But what if the patient remains informed, capable, and persistent despite all those efforts at persuasion?
Then the patient's informed autonomy must ultimately prevail. The text acknowledges that while the physician must try to persuade and educate, their efforts stop where the patient's right to informed self-determination begins. Here's where it gets really complicated in modern care. Financial barriers. The rising cost of care is a huge ethical issue because it directly compromises beneficence, the patient's best interest. It's an enormous conflict. Escalating drug prices, high copayments, and inadequate insurance coverage mean that patients literally cannot afford prescribed tests, medications, or interventions. This compromises their clinical outcome, which is a direct ethical failure of the system.
So what is the physician's practical ethical duty when faced with a patient who simply cannot afford the treatment?
The physician's duty extends far beyond just writing the prescription. They have to actively strive to prescribe indicated medications that are both affordable and acceptable to the patient.
And that requires proactive steps.
It does. Knowing the patient's insurance status, prescribing generics or covered alternatives when possible, and crucially, following up to see why prescriptions weren't filled or why doses are being skipped.
So the ethical duty involves advocacy and coordination with the whole team.
Absolutely.
Yeah.
Pharmacists, technicians, and social workers become ethical agents here. They help appeal for coverage of non-formulary products, they find patient assistance programs, or they secure funding. The physician is ethically bound to advocate reasonably for coverage exceptions when the formulary alternatives are ineffective or poorly tolerated by that specific individual.
Beyond cost, organizational and workplace conflicts can drain a physician's dedication. What systemic issues does Harrison's identify that negatively influence care quality? The list is pretty comprehensive. Inadequate staffing levels, unfair wages, deficiencies in equipment or infrastructure, overly rigid work hour limits, and especially corporate culture or workplace violence. These systemic issues create an environment of moral distress, making it incredibly difficult for a physician to deliver high-quality, patient-focused care. So the ethical obligation isn't just to the patient, but to the system that supports that patient.
It is. Physicians should work proactively with institutional leaders to advocate for policies and practices that actively support quality care centered on the patient's best interests. Ignoring these structural flaws is implicitly accepting lower quality care.
And finally, there's this conflict between evidence-based practice and individual patient needs. Guidelines are generally good, but when do they become an ethical constraint?
Well, while evidence-based guidelines and performance benchmarking generally serve the population's best interest, the physician's primary duty is always to the individual patient in the room.
Right.
Physicians must recognize when a generalized guideline recommendation may not serve that patient's interests because an exception or an alternative plan would provide substantially greater benefits to that person.
So competence involves knowing when to deviate and being able to ethically justify that deviation?
Precisely. The physician has to be familiar with the relevant guidelines, but they also have to be ready to recognize and advocate for reasonable exceptions when the evidence suggests that the individual patient needs something different.
This leads us back to justice, particularly in the context of resource distribution at a societal level. The text snarkily states that universal access to medically needed healthcare remains an unrealized moral aspiration globally, and especially in the United States. It's the greatest ethical failure of our systems. Patients with inadequate insurance, particularly those with chronic, complex diseases, often cannot afford needed care. The ethical mandate is clear. Physicians must advocate for affordable access to indicated care and work with institutions and policymakers to promote wider access for the community. But let's face the reality. During crises, allocation becomes unavoidable, whether it's a national drug shortage, a pandemic, or limited ICU beds. How must those allocation policies be structured to be fair?
The policies have to meet 4 rigorous criteria.
Yeah.
First, they must be fair, transparent, and accountable to the community. Second, they have to be responsive to the concerns of the affected parties and stakeholders.
Okay.
Third, they must be proportionate to the situation, meaning the severity of the limits matches the supply versus the need. And fourth, they have to be based on relevant criteria designed to achieve specific prioritization goals.
What are those prioritization goals? Because we've heard a lot of conflicting ideas during recent crises.
Fair processes should aim to prioritize patients who are most likely to suffer a large and irreversible decrement in health outcomes without intervention. They must also aim to mitigate health disparities, save the most lives overall, and promote the overall good of the community.
So why is a simple first-come, first-served approach often ethically flawed? It sounds equitable on the surface.
It's flawed because it completely ignores social context. It often disadvantages patients who face systemic barriers to access, those who lack transportation or childcare or the ability to take time off work.
Right.
An allocation policy that's committed to justice has to actively avoid discrimination based on non-relevant personal social characteristics, race, gender, disability, wealth, and should actively aspire to reduce disparities related to social determinants of health, like poverty or unstable housing.
So what is the final role of the individual physician when allocation is required?
The physician acts as a zealous patient advocate within the constraints set by society and sound policy. But the text stresses that ad hoc resource allocation by individual physicians is inconsistent, often unfair, and usually ineffective.
So it shouldn't be on them alone?
No. Major allocation decisions, like organ transplantation criteria or crisis standards of care, should be established at the institutional or public policy level with broad input. This frees the individual clinician from carrying that unbearable ethical burden alone. That analysis brings us to the internal life of the physician, the role of their character, their personal conflicts, and the psychological burden of the profession itself. Yes, we shift now from the external principles to the internal virtues.
If principles tell you what to do, virtue ethics tells you how to be. What is the core focus here? Virtue ethics focuses on the physician's character and their qualities. It promotes the cultivation of specific virtues: compassion, trustworthiness, humility, integrity, and intellectual honesty. Why are these virtues necessary if the physician is already following the 4 ethical principles?
Well, proponents argue that virtues act as the physician's moral operating system. If these characteristics are deeply ingrained, they'll guide the physician in unforeseen situations where principles might conflict. And
Okay.
critically, following principles without virtue can lead to a technically correct but, uncaring or emotionally distant relationship with the patient. Virtues ensure that the care is not just correct, but compassionate.
And professional oaths, like the Hippocratic Oath, fit into this system.
They serve as codes of ethics that articulate these ideals and values, representing the public commitment physicians make. And personal values, cultural, religious, philosophical, are also important and help physicians cope with moral distress.
But Harrison's gives a clear warning about relying too heavily on personal morality alone.
Yes, personal morality, while essential, is a limited guide in clinical practice. Physicians have specific role-based obligations, like obtaining informed consent and maintaining confidentiality, that extend beyond general personal obligations.
Because they serve everyone.
Because they serve a culturally and religiously diverse world. They must always be keenly aware that their personal beliefs are only one data point in a very complex decision-making process.
Let's tackle some specific areas where personal values clash with professional roles, starting with claims of conscience. This is highly charged today, whether it relates to abortion or physician aid in dying. Right.
Well-
If a physician has a deeply held conviction, often rooted in religion or philosophy, they may have a legally protected right to object to providing or referring patients for specific treatments. The ethical mandate here is a dual duty. The physician should not be forced to violate their conscience, but the patient must still receive medically appropriate and timely care. So how does an institution ethically manage that unavoidable tension?
The institution holds the collective ethical duty. It must accommodate the worker's objection by arranging for another professional to provide the service or ensuring a smooth, timely referral to another institution. The crucial part is that the care must be provided in a manner that avoids serious risk or suffering for the patient.
And is advanced disclosure required?
Absolutely. Ethically, patients who are seeking a relationship with a physician or an institution should be notified in advance of any conscientious objections to specific procedures. This is vital because the patient's insurance status or condition might severely limit their ability to switch providers later on.
And what are the firm limits on claims of conscience? Where do you draw the line?
The limits are crucial. Physicians cannot refuse to treat or discriminate against patients based on their inherent characteristics, things like race, sexual orientation, disability, gender identity, or diagnosis. Refusing care based on personal characteristics violates the core principle of respecting the patient and their fundamental need for help. Another frequent tension point is the physician as the gatekeeper. They are often asked to provide services that violate their clinical judgment. This happens all the time. A patient requesting cognitive-enhancing drugs for an exam when they don't have ADHD, or asking a doctor to sign unwarranted disability forms, or requesting excessive pain medication without medical necessity. The physician has to consider the risk to the patient, the public trust in the medical profession, and the fairness of their actions.
So when must the physician decline the request, even when they're facing a difficult patient conversation?
If fulfilling the request requires deception, is unfair to the system, jeopardizes professional responsibilities, undermines the physician's credibility, or is just inconsistent with the patient's best medical interests, the physician has to decline.
And then explain why.
And then clearly and kindly explain the reasons why, maintaining their integrity while still respecting the patient's goals.
We also see a classic ethical tension between trainee learning and patient care. Future physicians have to learn how to do procedures, but that often means increased time, discomfort, or potential risk for the patient being treated right now. How do institutions manage this ethical compromise?
The focus is on mitigation and transparency. Institutions are increasingly relying on simulation-based clinical skills laboratories, where trainees can demonstrate proficiency before they perform invasive procedures on actual patients. Some hospitals even establish specialized services where experienced faculty directly supervise interns until their competency is certified.
And what is the ethical imperative regarding patient consent for trainee involvement?
It is essential that patients are asked for consent for trainee participation, especially for intimate examinations or invasive procedures. Patients have to be fully informed about who is providing their care and the level of supervision present. Failing to introduce trainees who will be performing procedures undermines trust and voids the patient's informed choice. But most patients, when they're respectfully asked, are supportive of the education process.
Okay, so let's talk about moral distress and error management. Physicians accept significant occupational risks, exposure to infectious agents, patient violence, grueling schedules. The institution has a clear ethical duty here.
It does.
What does that institutional duty entail?
It involves prevention, training, and support. Institutions must provide proper training, adequate resources, and essential emotional and psychological support. Clinical leaders have to acknowledge the fears that physicians and nurses have about personal safety and job strain and take tangible steps to mitigate the impact of these risks on their workforce.
And this ties directly into moral distress, which we mentioned earlier. How does Harrison's define this crippling phenomenon?
Moral distress occurs when clinicians know the ethically appropriate action, but they feel blocked or hindered from performing it by systemic issues, like rigid institutional policies, hierarchical structures, resource limitations, or just an unsupportive culture.
And the consequences are severe.
They are. They include burnout, anger, anxiety, fatigue, and depression, which inevitably degrade the quality of care. Mitigating moral distress requires a healthy work environment that's characterized by open communication, mutual respect, and systems that allow physicians to voice ethical concerns and seek resolution.
Let's address medical errors. Errors are inevitable, but the response to them is an ethical mandate.
Yes, and most errors stem from flaws in the healthcare delivery system, not from blameworthy individual behavior. The ethical shift advocated by Harrison's is toward adopting what's called a communication and resolution system.
A communication and resolution system.
Yeah.
So that shifts the focus from individual culpability to system improvement.
Exactly. This system encourages open and honest reporting of errors, which is essential for quality improvement. The non-punitive approach shifts the focus away from individual blame toward system redesign and collective improvement in safety.
What is the physician's immediate duty to the patient after an error occurs?
The physician shows ultimate respect by disclosing and explaining the error, offering a sincere apology, and providing appropriate compensation for the harm done. Errors must always be used as learning opportunities to improve care quality. Professional discipline should be reserved only for cases involving gross incompetence, reckless behavior, or boundary violations.
And finally, physician impairment due to alcohol, drugs, or illness. Colleagues often hesitate to report.
The medical profession is largely self-regulating, and society relies on physicians to protect patients. Colleagues have a clear, overriding duty to protect patients and help their impaired colleague. This requires reporting concerns to supervisors. Institutions must have established programs for assessing competence and providing confidential support to help the impaired physician recover and return to safe practice. Okay, the final ethical issue in practice concerns conflicts of interest. The principle is clear. Patient interests are paramount. They must always be placed above the physician's self-interest or the interests of third parties like hospitals or insurers. Since conflicts of interest are, let's face it, unavoidable in a commercialized healthcare system, the ethical requirement is transparency, active disclosure, and management, or recusal when the conflict is too severe.
And it's not just financial conflicts.
Correct. Physicians often face conflicts of commitment. Their time spent on research or administrative duties or their own career aspirations might conflict with a patient's immediate needs. They must constantly prioritize the patient's interests, using disclosure and institutional oversight to manage these non-financial conflicts.
How do financial incentives and different payment models create specific opposing ethical conflicts?
This is fascinating because the ethical pressure really shifts depending on the payment structure. In a value-based model, where physicians are rewarded for efficiency and outcomes, the pressure might be to avoid complex or chronically ill patients who are difficult to manage, which compromises justice.
Right.
Conversely, the traditional fee-for-service model might encourage the ordering of unnecessary interventions or referrals to facilities where the physician has a financial stake, or prolonged stays, which compromises non-maleficence.
So what is the core ethical principle that must transcend both of these incentive models?
Regardless of the financial structure, the physician should recommend only available care that is in the patient's best interests, no more and no less. The treatment decision has to remain evidence-based and patient-centered, shielded from financial bias.
Let's talk about the scrutiny of relationships with pharmaceutical and device companies.
This is essential for maintaining public trust. Many medical centers now ban industry gifts like branded meals or pens to reduce the risk of undue influence or even subconscious feelings of reciprocity. The Federal Open Payments website provides public data on payments made to individual physicians, which promotes transparency.
What is the nuance required in managing these industry relationships?
The challenge is distinguishing between truly beneficial scientific consulting and research contracts, which promote academic missions and clinical progress, and payments for promotional speaking and sales-focused activities. The former should be encouraged. The latter must be carefully scrutinized and minimized to ensure that patient care decisions are not being influenced by marketing dollars.
Okay, we've covered the traditional conflicts. Now let's pivot and give significant time to the novel frontiers that Harrison's identifies, the ethical complexity driven by accelerating innovation and globalization.
The scientific promise of these technologies is immense, but the ethical challenges scale equally.
We're talking about genome sequencing, CRISPR-Cas9 gene editing, and cell-based therapies. What is the overriding ethical mandate for these groundbreaking innovations?
The mandate is rigor. Even with strong scientific plausibility, these groundbreaking technologies must be evaluated in rigorous clinical studies for both efficacy and safety before they're adopted into routine practice. Physicians have an ethical duty to stay current on the evidence and help patients understand the findings, correcting misunderstandings about unproven claims.
Let's zoom in on artificial intelligence, AI, and machine learning, ML. Where are these algorithms being used in diagnosis right now?
AI algorithms are becoming crucial for diagnosis by analyzing large volumes of data. So, interpreting images in radiology, pathology slides, retinal scans, or predicting outcomes like surgical complications or hospital readmissions.
What is the physician's primary ethical concern when using these predictive tools?
The physician must be confident that the algorithms they use are clinically meaningful, that they're unbiased, and that they do not lead to worse patient outcomes or propagate disparities. The critical risk here is algorithmic bias.
Right.
If the data used to train the AI, the training set, disproportionately reflects one specific population, the resulting algorithm may perform poorly or even dangerously when it's applied to unrepresented groups.
And what about the newer generative AI or large language models, LLMs? These are being used to reduce administrative burden.
That's the massive potential benefit mitigating physician burnout by drafting clinical notes or summaries or appealing insurance denials. However, the key ethical risk is hallucination.
They just make things up.
They can confidently provide false, medically inaccurate information. The physician's ethical duty is to ensure they are the final arbiter of accuracy and that the use of these tools does not negatively affect patient outcomes or the clarity of clinical records. You cannot delegate the duty of accuracy to a chatbot. Let's discuss the elephant in the room, the cost of high-tech therapies. We have approved cell and gene therapies for conditions like sickle cell disease, but the price tag is staggering. These are curative treatments representing massive advances. But therapies like CAR T-cell therapy can cost hundreds of thousands or even millions of dollars. The high cost severely limits access, which violates the principle of justice.
So what can doctors do?
Physicians must ethically engage in public discussion about resource allocation and fair access to these essential but expensive innovations. The technology means very little if only the wealthy can afford it.
And what about the danger posed by patients seeking unproven claims?
This is a grave ethical and safety risk. Claims of cures through unproven stem cell or gene-based therapies that are often promoted in unregulated clinics pose significant health and financial risks without any evidence of benefit. Physicians must distinguish between approved, evidence-based therapies and these unproven claims, and must direct interested patients only toward well-designed, legitimate clinical trials. A final brief mention of the ultimate ethical line: germline editing. Germline gene editing, which involves making heritable changes in embryos or blastocysts, raises profound ethical questions about humanity and unintended consequences. It remains prohibited in the United States and many other countries.
Okay, so let's shift to ethics in clinical research. This is essential for medical progress, but it presents a unique and continuous ethical tension.
It does.
What is the core ethical conflict here? The conflict is that participants face inconvenience and risks, not primarily for their direct personal benefit, but for the benefit of future scientific knowledge. To mitigate this, strict ethical requirements are mandatory. Rigorous study design, minimizing risk, obtaining informed and voluntary consent, and receiving approval from an institutional review board, or IOB. What is the specific ethical burden on the physician who also acts as an investigator?
Physician investigators have to be acutely aware of the inherent tension between their duties as a researcher and their duties as a care provider. They have to complete research ethics training, and the IRB's role is particularly important in ensuring risks are minimized and acceptable, especially when vulnerable participants are involved. And finally, we have these new forms of research using passively collected data: electronic health records, mobile devices, old tissue specimens. What are the ethical concerns when there's no physical risk? These forms of research generate massive amounts of knowledge, but they raise significant concerns about consent, privacy, confidentiality, and potential psychosocial risks. Even though there is no physical risk, the sheer volume of personal data necessitates careful ethical oversight to ensure the data is anonymized and privacy is protected.
And Harrison's concludes by addressing the ethics of medicine in a truly global context,
Yeah.
starting with international research, which often involves multiple sites across national borders.
Physician investigators must adhere to federal regulations, international guidelines, and local laws. Success requires true partnership with local researchers and communities, ensuring that the research respects diverse societal, legal, and cultural norms and benefits the population being studied, not just the sponsoring country.
And finally, international clinical experiences, when physicians travel abroad to provide care.
While humanitarian and broadening, these arrangements raise serious ethical challenges due to differences in cultural norms, expectations, standards of clinical practice, and severe resource limitations. Visiting professionals have to receive training and mentoring, respect local customs, collaborate closely with local professionals, and critically recognize their own limits. They must never impose high-resource standards in a low-resource setting if it's unsustainable or inappropriate for the local context.
This has been an extraordinarily comprehensive deep dive into what it truly means to practice ethical medicine today. Let's try to synthesize the most critical takeaways for our listener.
This is the distilled knowledge for anyone preparing for the challenges of modern clinical practice. Okay, first, clinical ethics rests on that three-part framework: respect for autonomy, the combined duties of beneficence and non-maleficence, doing good while minimizing harm, and justice or fairness. These serve as the unbreakable moral spine for every decision. Second, informed consent is a continuous process of honest, empathic disclosure that aims for genuine understanding and choice, not just a signature. Patient capacity has to be carefully assessed, and when surrogates step in, their decisions must be strictly guided by the patient's known values and goals.
Third, physicians face profound conflict between the patient's best interests and systemic barriers, including high drug costs and misaligned financial incentives. The ethical duty extends beyond the clinic door. The physician must advocate fiercely for affordable, indicated care and work against policies that undermine patient well-being.
Fourth, fair resource allocation, especially during shortages, requires transparent, accountable policies based on morally relevant criteria like need and probability of benefit. These policies must actively aim to mitigate health disparities and never discriminate based on wealth or social characteristics. Fifth, new technologies like artificial intelligence introduce novel requirements. Physicians must ensure their algorithms are unbiased and medically accurate. Meanwhile, the high cost of life-saving gene therapies forces an urgent ethical debate about fair access to innovation. And finally, the physician must manage significant internal challenges: moral distress, claims of conscience, and the gatekeeper role, while promoting open system-focused protocols for reporting medical errors, fundamentally shifting the culture from individual blame to collective safety improvement.
The complexity is daunting, but the clarity of the ethical standards provided by Harrison's is essential. It really proves that medicine is truly a moral discipline. It does. And the final provocative thought I want to leave you with centers on that collision between innovation and reality. We have these revolutionary, sometimes curative gene therapies that are proven and safe, yet they carry millions of dollars in costs. We hold the moral aspiration of universal access to medically needed care. The question for the next generation of physicians is, beyond advocating for the individual patient in the room, what is the collective ethical role of the medical profession in addressing the affordability crisis of innovative medicine itself? A profound challenge that defines the future of healthcare. Thank you for diving deep with us.